Hello. Dr. Vinod.
Yeah, so that is what data table does. But that is Pranav, that's what data table does. What it does is the moment I change it from, see, what it is doing is when I say I want correlation.
Dr. Kapoor?
Yes, good evening, good evening, good evening. We'll wait
Hi,
for...
Dr. Kapoor, can you hear me?
Yes, yes.
Can
Good
you
evening.
hear me?
Yes.
You are mute. Are you mute?
Yeah, maybe you can share your screen so that you can.
Okay. Can you hear me now?
Yes, we can hear you. Yes.
Can I share my slide and see whether it's working?
Yes, please. Yes, please.
Hello, sir.
Hi.
Hello.
Hi.
How are you?
Fine, thank you. Yes, we can see.
No videos, just medical management. Okay.
Okay, thank you.
If I am overshooting time, you just tell me. I will stop at that level. Okay. Not much. 15 minutes, no?
15 minutes, yes.
I may overshoot a little bit. Okay, if you don't mind. Okay, I'll stop sharing now. Okay, then.
Yes. No, it's okay because you are the first, so that's fine. We have another couple of minutes.
Oh, it's okay.
Good evening, Mathew. How are you?
Hello, sir. How are you?
All well. Nice to see you. I missed
Nice, sir.
seeing you
Thanks
in
a lot.
Jaipur in person, but I'm seeing you on the Zoom. That is a plus.
So, Dr. Saraswat, in case Dr. Chaudhary is not able to join, I'll request you to chair Dr. Phillips' presentation.
Yeah, Dr. Kapoor, you know that he's my teacher. And when I came to SG Vijay, actually he showed me.
Yeah, for about 1 week, I guess.
No. Almost 3 weeks were there.
Okay, 3 weeks.
As an observer.
Yes,
As an
thank
observer.
you.
During
Yeah.
our DM time, no, we get option to, we can go outside and
Yes,
visit.
yes.
So when Dr. Nayak was there, a lot of
Yeah.
visitors from all over the country.
It was wonderful. Thanks a lot.
Hi, Philip, Mathew. Good
Hi.
evening.
Hi, Sadiq Sikora. How are you? A long time.
Hello,
no?
sir. Dr. Kapoor, Dr. Saraswat.
Hi, good evening.
How are you, Philip? I'm seeing you after a long time.
I am doing very well. Thanks a lot.
All good?
Everything good.
Lizzie Hospital.
Lizzie Hospital. Come down to Kochi sometime.
Yeah, I did come, but for a very short period.
Okay.
But next time I'll get in touch. But
Yes.
it's been good to see you.
Thank you so much. Same to you.
Himanshi, are you there?
Yes, sir.
Yes, good evening.
Good evening, sir.
Himanshi is the resource person in Dwarika Clinic, Dr. Avinash Tank's clinic. They provide the technical support for all our activities. And Anand, you are there? Anand Nagar?
Yes, sir.
Put your video on for a minute. So my colleague, Dr. Anand Nagar, he is the coordinator for all the academic activities of Jaipur Surgical Tutorial.
Okay. Hi, Anand. Hi, Himanshu.
He's been running the show
Sir,
for last
good evening, sir.
more than 2.5 years.
Yes. Good evening, sir.
So Himanshi, the delegates will put their questions on the YouTube chat.
Will we know that? Who will transfer to the chat box?
Himanshi? No, actually, this time we are trying a new thing that Zoom is only for the panelists, and the delegates are watching it on YouTube channel, and they will put their questions there. So maybe I'll just speak to Himanshi about it.
No. Somebody.
Himanshi,
Actually, Mathew, you can open the chat box yourself and see the questions, and depending on the time available.
Okay.
no, Dr. Saraswat, this time there is a slight change because the delegates have joined on YouTube.
Yeah.
So they will put their questions there, and Himanshi will keep sending them to us on the chat box.
That will be fine. That will be fine.
All we have to do is to look at the chat box.
Yes.
Answer the questions.
Good evening.
Yeah, good evening, Dr. Yogesh. Dr. Yogesh Vashisht is a colleague who's currently in Saudi Arabia. And
Please clarify, do I have to log in also in that YouTube channel or?
No, this is fine. For you, this is fine.
Okay, where to put the questions? Here in the chat?
if you want to put any question, you can put on the chat here, but the delegates will put it on the YouTube.
Okay.
Dr. Vashisht, you have to answer the questions. You don't have to put the questions.
Yes. I will. Okay. So it's 7. Yeah, it's 7. Let's start. Good evening, everyone. I welcome all of you on behalf of Mahatma Gandhi Medical College and Hospital in Jaipur, where I have been working for last more than 2.5 years after finishing my term of more than 3 decades at the SGPGIMS in Lucknow. After moving here, that was the COVID time. So we started an online education portal called Jaipur Surgical Tutorial, which my younger faculty colleague, Dr. Anand Nagar, who is an associate professor in HPV surgery and liver transplant at my new institution, has been coordinating and helping me in organizing these activities. We conducted a session every Saturday, 9 to 10 Indian time in the morning, which is available for anybody to join. So those of you who want to join, please contact Dr. Anand Nagar. I'll put his number. I'll announce his number actually, because this time the delegates will not be able to see the chat. And then 3 months ago, we thought that we will start a monthly online masterclass. So we did the first masterclass on living donor liver transplant. The second one was on safe cholecystectomy, and this is the third masterclass on chronic pancreatitis. So we'll have 2 hours today and 2 hours tomorrow. And I'm very happy that all the leading experts on chronic pancreatitis in the country have accepted our request to join as faculty speaker and panelists. So Dr. Anand's number if you want to join a Jaipur Surgical Tutorial for the delegates, please note the India country code is +91, and then it is 95,997,30280. I'll try to prepare a slide and project it in between also. +9195,997,30280. So without any further delay, I think I will request Dr. Saraswat to kindly chair this session. As Dr. Chaudhary, he is actually traveling to Lucknow and he was not sure whether he will be able to join or not. So in case he joins, he'll join in between, but I'll request Dr. Saraswat to chair the session, first session, which is to be presented by Dr. Philip Mathew from Lisi Hospital in Kochi, which is on medical management of chronic pancreatitis. Dr. Saraswat, please.
Thank you, Vinay. Good evening to all the faculty members, panelists, as well as the delegates who have logged in for this masterclass. And I'd like to congratulate Vinay on this wonderful initiative. Online teaching is reaching a lot of audiences and becoming increasingly popular. It's a great pleasure for me to welcome Dr. Mathew Philip, who's the Chief of Gastroenterology, and he is currently the I think you are the president-elect, Mathew, if I'm not wrong, for the ISG?
Secretary General now.
Secretary General of the ISG right now, and he's been president of the SGI, the Society of Gastrointestinal Endoscopy in India in the past. He is at the Lisi Hospital in Kochi. Chronic pancreatitis is one of the areas of interest and active work for him. And I request him to talk to us about the medical management of chronic pancreatitis. Mathew.
Thank you, Professor Saraswat, for the kind introduction. And thanks, Dr. Kapoor, for allowing me to, or giving me this opportunity to be with you and share some of the views in medical management of chronic pancreatitis. I bring in greetings from Indian Society of Gastroenterology. And we know that chronic pancreatitis is characterized by an irreversible destruction of pancreatic paragamy and ductal system, which occurs due to a long-standing inflammation, ultimately leading on to fibrosis, scarring, and this could be due to many reasons. Could be genetic, could be environmental, or other risk factors like alcohol, etc., etc. And the incidence varies from countries to country, but in average, it goes 1.6 to 23% in 1 lakh population in very different countries. And probably the prevalence is increasing because of the lifestyle changes which occurs in our community now. If you look at the management protocol, non-surgical management of protocol of chronic pancreatitis, and a lot of new developments has occurred, not only in medical therapy, but also in endoscopic therapy. Of course, surgery is the ultimate step, and it's been evolutionized repeatedly, and we have got wonderful surgeons across India all over the world doing tremendous pancreatic work. In my talk, I would be touching upon, talking on the following outline. I will just introduce about a topic, and then how do you manage pain, how do you manage exocrine pancreatitis insufficiency, endocrine insufficiency, nutrition, which is a very important aspect, and bring in some new concepts like painless chronic pancreatitis. What does it mean? Acute or chronic pancreatitis, is it different, or how to manage? And what is the concept of group pancreatitis? So when you look at the classification of chronic pancreatitis, it has been classified in different ways, and depending upon the different aspects of chronic pancreatitis. For example, Manchester classification looked at imaging modalities and clinical signs of chronic pancreatitis. And ABC classification is almost similar to that of Manchester. And M and HIM is stage, severity, and clinical findings. And it actually looks on the severity and staging of the disease, staging of the pancreatitis. And Tiger O, that is the etiological classification. Now, Rosemount is, which is more commonly used by as endoscopists, is US-based criteria, that is the Rosemount one. And looking at the risk factor-based classification systems, we have different types of risk factors like oxidative stress, toxic metabolites, necrosis, and other autoimmune, recurrent and severe acute pancreatitis, leading on to stone and duct obstruction. And there are different types of risk factors. Ultimately, a mixture of these can lead on to sometimes chronic pancreatitis. So when you look at the phenotypic or the morphological one, it can be again a calcifying one, or where the duct is not dilated much, but you see focal calcification in the pancreas, or you can have an obstructive one, dilated duct, with either due to a stricture or a stone obstructing, or it could be, at least in a minority, it could be autoimmune related, or a disease which is more focal producing problems. There is a group pancreatitis. So when you make a diagnosis, is basically by imaging, clinical signs, etc. And even in a plain X-ray, you can sometimes see the pancreatic stones. Ultrasound abdomen is a good modality, easily available. But many times we may not be able to see the pancreas properly, and assessment may not be easily done. So if you ask me what are the major modalities that one is cross-sectional imaging, like CT scan or MRI and endoscopic ultrasound. But the most commonly used one and the best one to detect stones would be the CT scan. And MRI will give you an analysis of the ductal system. So if you want to look, the best modality, if you ask me, I would say it's CT scan. But if you want to look at the ductal system, it will be MRI. But if you ask which is the earliest one to diagnose, I think endoscopic ultrasound will tell us very definitely the parenchymal changes and early ductal changes. So endoscopic ultrasound is another modality which can, but it's an invasive one. So CT and MRI will be there. So when you come to the medical management, what will be our main aims? We know that everyone who is treated for illness, they want a relief of symptoms. And pain management is one of the key factor in managing chronic pancreatitis. And another thing is, when you treat, we also want the disease should get arrested at same level or improve, but never it should progress. So our aim is like that, but we need not succeed in always like that. And also, many times they have complications like exocrine, endocrine insufficiency, associated features, or local complications related to chronic pancreatitis. All these needs to be addressed. So whatever we do, many times, it is not universal to every patient. You need to have an individualized or personalized approach. And many patients, some may remain symptomatic despite whatever type of therapy you do. So major areas of focus on management of chronic pancreatitis: one is pain, second is nutrition, very important, grossly neglected one, and exocrine or not looked after properly, exocrine insufficiency, endocrine insufficiency, and complications. The complications, there are multiple complications that can occur because of chronic pancreatitis, which can be either in the gland itself and because of the or they can develop endocrine insufficiency and strictures occurring in the pancreatic duct, stricture occurring in the bile duct, pseudocyst, and stones dual stenosis, malnutrition occurring secondary to chronic pancreatitis, vascular complications, and remote long-term complications like malignancy. So, but when you look at the management of chronic pancreatitis, there are a multitude of factors which should be looked in. So it is not an easy job. There are multiple factors involved in that. It actually, there may be poor intake, there may be a malnutrition, there may be a hypercatabolic state, diabetes, neuropathy, SIBO, oxidative stress. So many factors are involved. There are substance abuse, alcoholism, ongoing inflammation, so many factors. So it's not an easy task to treat chronic pancreatitis. So many factors are involved. And even some patients go into depression, anxiety, either due to the disease per se or because of substance abuse. So when you look at the management of chronic pancreatitis, we have got a step. There is the initial one is the medical management. Then you can go for endoscopic therapy or surgery. I'll be concentrating only on the medical aspect of it. So when you look at the general measures of management, I think the most important thing is you have to ask the patient to stop alcohol and tobacco. Why this is important? If alcohol is the etiology, we know that the progression of the disease can be delayed by stopping alcohol. Why tobacco is important? It also shows that this can also partly cause symptoms in chronic pancreatitis, but most importantly, tobacco can actually induce pancreatic carcinoma. We know that chronic pancreatitis is a disease, it's a high risk factor for pancreatic carcinoma. And the impact on pain of these tobacco and alcohol is quite variable, but now some degree of pain relief is noted when they abstain from alcohol. So coming to one of the major areas of management of chronic pancreatitis is nutrition. I think why nutrition is important, because in malnutrition, there are so many contributive factors which can occur in chronic pancreatitis. One is the pancreatic enzyme replacement therapy. Secondarily, they have got anorexia mainly because of abdominal pain, or a fear of abdominal pain actually prevents them from taking adequate food. And many times they can have nausea, vomiting, and sometimes patients can have gastroparesis because of diabetes-related issues, or because of local complication like group pancreatitis, which can cause vomiting, gastric outlet compromise, and consumption of alcohol can affect their nutritional status. Substance abuse can affect, and even diabetes mellitus will affect their nutritional status. So initially, how do you start feeding them? Now, diet and supplement, initial concept was to reduce the fat intake and give them small meals and avoid dehydration, etc. But low-fat meals, is not supported by any data and no more recommended. And we also know that gastroparesis sometimes, which can occur in this patient because of diabetes, they also, in those patients, I think, smaller meals may minimize symptoms. And generally, when you talk, we should avoid very low-fat diet, except in those patients with severe pain where they cannot tolerate any food. Otherwise, it is generally avoided that you take normal fat food, and especially when there is pancreatic enzyme insufficiency and you are giving pancreatic enzyme replacement therapy, and normal diet with a normal fat intake should be good. This is also important to prevent development of vitamin deficiencies, which is fat dependent and ultimately lead to selective malnutrition also. And we also have to make sure that their bone strength should be very good, because vitamin D deficiency is quite common and we need to supplement with vitamin D and calcium. And coming to nutrition supplementation with the medium chain triglyceride oil, we know that pancreatic digestion is not required in medium chain triglyceride, because I belong to Kerala. We have a lot of coconut oil, and which is rich in MCTD, medium triglycerides. But there is no data to suggest that to replace this one, except in those patients where they are not able to tolerate other types of fat. We can try that. Nutritional assessment is a very important aspect in that, and actually we should do a proper nutritional assessment, and not only based on body mass index. Actually body mass index based assessment alone is not adequate to predict the muscle mass and function status. Actually the percentage of weight loss is a better indicator for malnutrition rather than just doing a single body mass index. So this can be done in a different form. You can take a clinical symptom, you look for organ dysfunction, selective vitamin deficiency, anthropometry, biochemical examination. All these are quite important. And one area which actually is coming in a big way is the diagnosis of sarcopenia. When you do a CT scan in a patient with chronic pancreatitis, always try to look at the muscle mass. That will also give us an idea of how bad is the nutritional status of this patient. So coming to what are the recommendations, we do this patient for diet. I would suggest that they should be encouraged to follow a normal, healthy eating advice, especially if the patient is otherwise okay, not very seriously symptomatic. And you have to give pancreatic enzyme replacement, but this should be enzyme insufficiency, exocrine insufficiency should be corrected with especially those who are nutritionally compromised. Dietary counseling should be done by an experienced dietitian and should be individualized. There is nothing called all for same diet for everyone, but should be restricted. It should be modified to each person's of this need and region, etc. And again, I'm telling dietary fat restriction should be avoided, especially in patients on pancreatic enzyme replacement therapy and when they are malnourished. But try to avoid very high fiber diets, because that can actually produce sometimes bloating and symptoms, and especially the PERT absorption can be sometimes affected. So in those patients, I think high fiber diet can be reduced. So in generally, you give small, frequent, and high energy meals for those patients with malnutrition.
3 more minutes, Dr. Philip.
Pardon?
3 more minutes, please.
So coming to the management of pain associated with the chronic pancreatitis, now we know that the mechanism of this is ductal hypertension, or inflammatory or neurogenic, or because of the complications you all discussed. When you look at the pain in chronic pancreatitis, it can be classified depending upon the severity of pain as well as the frequency of pain. And this could be due to multiple mechanisms you already discussed on that. But the neuropathic mechanisms have come in a big way, and it has been found that something outside the pancreas also is responsible for causing pain, and this needs to be addressed on that. So when you look at for pain for chronic pancreatitis, always if the patient is not responding to the therapy which you are trying to give, and then you should rule out other etiologies also. And imaging is quite important when you try to treat these patients and find out whether there is an extra cause, like especially for malignancy, etc., which occurs in these patients. And I think the best modality for pain is to start with acetaminophen or paracetamol with or without antispasmodic. NSAID should be reduced because of the gastric side effect. And you want to change out to a less or a non-narcotic opioid agents like tramadol, which is actually a better option as a second one. And the third one, actually a third level, I will add as a adjunctive agents, like antidepressants or other antidepressants, pregabalin or gabapentin, etc. But the real opioid or narcotics like morphine, etc., I will try to take it only on the later stage. What is the role of antioxidants? This has been brought in initially as a good modality for reducing pain, and an Indian study has shown excellent result. But many studies have shown that this could not be replicated. But you need to, if at all you want to give, you have to give a good dose of methionine, that is at least 1000 milligram on that. So does pancreatic enzyme replacement therapy reduce pain? The studies have shown that that is not, and it is not able to demonstrate any benefit on that. So when you treat a pain in a chronic pancreatitis, you have to find out what is the cause of the pancreatic pain, and you try to look at lifestyle modification, nutrition, etc., and start them. Also ask them to stop alcohol, smoking, etc., and then start them on medications. And if they are okay, then continue to follow them. If they are not, then you have to look for any structural abnormalities and try to address on that. And always look at the psychological aspects and try to treat that. And if there is neurological manifestations, or if you think the neurological causes are there, you need to add on these drugs like gabapentin, etc. Finally, if they're not going on, getting on better, and if there is a large disease or an obstruction or a stricture, then you go for endotherapy or surgical management. Coming to exocrine insufficiency, I think it is quite important that nearly 90% of pancreatic function should be lost if somebody gets steatorrhea. And this can be due, the manifestations can be very varied. It can be steatorrhea, weight loss, malnutrition, metabolic dawn disease, and even vitamin and mineral deficiencies of that. Nearly, in chronic pancreatitis, nearly 85% will have some sort of pancreatic enzyme insufficiency. The clinical manifestations can be quite variable, and most common clinical symptom the patient says steatorrhea, but most important thing is not that, because subclinically they can go to weight loss and malnutrition and low bone mineral densities. There are multiple challenges when we treat this patient. I think the most important thing is the financial impact on that. And for diagnosis, you need not always do a full stool analysis test, but you can have a combination of either 2 of these, nutritional evaluation or symptoms of maldigestion, or if you are able to afford, you can do a test on that. The simplest test is a fecal elastase test, and if depending upon the values, we can suggest whether it's or not. PA is not there. So what are the goals of therapy for PET or pancreatic enzyme replacement therapy? Is to correct pancreatic enzyme exocrine insufficiency and improve malnutrition. The dosing is, what I practice is that start with a dose of 25 to 40,000 units with meals, and then 10,000 units with snacks. That is quite variable, and monitor for symptoms and weight gain, and then you adjust the dosing. And this should be taken along with meals, preferably at the first bolus of food. And if you don't treat adequately, you can have multiple complications like malnutrition induced and malabsorption induced problems which can occur. And when you look at the algorithm,
if you could summarize in a minute.
that's coming to that, sir. And when you actually coming to the algorithm, it is found that there is inadequate response. Then only you should think about adding gastric acid suppression. And when there is not response, always look for other causes also. And endocrine insufficiency is basically the type 3 C diabetes mellitus, and it has got a brittle diabetes. So you need an endocrinist opinion for all these things. Coming to group pancreatitis is actually.
I think we will leave that because we will cover it in the panel discussion. Yeah.
And acute on chronic pancreatitis is an area which actually is gaining more importance, and it is actually managed slightly differently. And alcohol is a risk factor on that. When you look at the CT scan, you can see that there are chronic pancreatitis with areas of fluid collection. This is actually is suggestive of acute non-chronic pancreatitis. Painless chronic pancreatitis is a new entity, and it is found that 12% of patients with chronic pancreatitis, they have no pain to start with. And mainly these are diagnosed on imaging studies. And the functional pancreatic insufficiencies are not very severe when compared to chronic pancreatitis, classically seen in older age. And there is low prevalence of recurrent acute pancreatitis, other complications of chronic pancreatitis.
I think we'll take the
So take home points are medical management of chronic pancreatitis is complex and should be individualized. And a proper diagnosis is quite essential. Alcohol and smoking should be discontinued. Nutritional assessment and replenishment of plays a very important role in that. And pain management is the key factor, and it should be individualized. Pancreatic enzyme deficiency needs to be diagnosed early and treated adequately. Diabetes is quite brittle and should be treated by an endocrinologist. And in a new onset pain with weight loss, imaging is essential to rule out malignancy. Thank you so much for a patient hearing.
Dr. Saraswat, you can take up the questions, please.
Thank you, Mathew. You've been covered a huge area in a very small period of time, and you've hit the highlights in most of them. Now, if you are looking at the chat box, maybe you can open the chat box yourself, Mathew. Dr. H. Ramesh has a rather long-winded question for you, so if you could please read it out and reply.
I would like to ask MB, if it is not true that we need to check the presence and severity of pain and the presence and absence of complication by reasonably comprehensive imaging, rather than simply following a stepwise medical endoscopic surgery route. I think he's right. See, the question is not, it's rather a statement rather than a question. But, I think, always it's an imaging is very, very important rather than just going by step by step. Many times, we start with medical management. Sometimes we switch over immediately to surgical management rather than waiting for medical management for long. I don't know whether I have answered.
Time allowed doesn't really tell us about detailed assessment of pain, pain severity, pain patterns to answer Dr. Ramesh's question. The steps in the management are, as Mathew has said, but how do you proceed from A to B to C? I guess it needs more time and individualized patients to discuss.
15 minutes, you cannot even discuss pain management.
Yes, indeed. So I think we can move to the
I think what Dr. Ramesh probably wants to know is, are there any patients in whom you don't start with medical management? Are there any patients which directly go to intervention, whether endoscopic or surgical?
Yes, sir. If the patient is having a complication, like, a patient has got already a mass, and if it looks like a malignancy, or a patient has got acute on chronic pancreatitis first presentation, and there is a big stone impacted there, though conservatively manage for time being, and then take up the patient for surgery or endotherapy. Or the patient has come with a recurrent acute pancreatitis, and there is a pancreas divisum. You need that the patient requires a pancreatic stenting. Or a patient has got a dominant structure in the pancreatic head, endotherapy versus surgery needs to be addressed on that. Straight away surgery, I think, we have to see a big chunk of stones. Actually, I want to show some slides also, but big chunk of stones. Hardly there is any role for endotherapy. In those patients, after conservative treatment, if this is not responding, we'll immediately go for surgery. But I think every patient, there should be some role for conservative medical therapy, at least to improve the nutritional status and assess for pancreatic enzyme insufficiency and treat, also look for diabetes status. So without that, we cannot just take away patient.
Okay, I think can we move to the next question? There are a couple more to cover, Mathew. How does one calculate requirements and dose of PERT?
Yes, that's why I told you, when we give for a major meals, look at the pattern of food he's taking. And I think, the commonest meal which we take in India requires at least 25,000 to 40,000, depending upon the fat content you take. So what happens in many patients, they stop taking, and even the physicians recommend not to take fat, which is a wrong thing. If you want to improve the nutrition status of that, of course, during an acute pain, you advise them not to take fatty food. Otherwise, I would suggest that 25,000 to 40,000 per meal, a major meal, is the standard one. And now we have even a preparation available. We can actually, one pressing, you can get 10,000 units. So you can actually, depending on the type of food you take, you can add that. Western diets requires more. Of course, I agree that their recommendation is 60,000 to 75,000. But in India, what I practice is 25,000 to 40,000 per major meal. Of course, it's a costly.
In continuation with that, you could take up Dr. Kamaljeet's question about differences between dosage and types of formulations for pain versus exocrine insufficiency. I thought you said that there is no place for enzyme replacement therapy.
I did not show the slide of market preparations available. I have a slide of that because that doesn't look good. But generally what we use is for pancreatic pain. At present, we generally don't use PERT as a line of management. But it's basically for pancreatic enzyme insufficiency. And those in diabetic, if they are not improving, you have to see whether they have got addition of pancreatic enzyme replacement improves their diabetic status also. Because malnutrition, impaired absorption, maldigestion, all produces even poor diabetes control also. Then another is role of celiac axis block. I think Dr. You are going to talk on that.
Yes, Dr. Nipun is going to cover that tomorrow. But in case you want to make a quick comment about it.
Actually, I tell you, in patients with chronic pancreatitis, celiac block is not a wonderful thing. But in pancreatic malignancy, celiac neurolysis makes sense. Why? Because, I have done it earlier, now I stopped it. In very desperate situations, you can try. Because, you are injecting steroids there. And this is not a permanent solution. It is a temporary solution. And I think, it should be reserved for really, really important patients, really very selective patients. And I generally don't do that. Role of celiac, and then is duration of opioid in CP. It is quite variable, no? If the patient has got a large duct disease, I won't wait for long. I'll take the patient for surgery or endotherapy, what was necessary. Small duct disease, many times we have to put them on that. But I tell many times I have seen these patients are on substance abuse, that they are continuing on alcohol. In those patients, has to be handled well. Otherwise, I think, duration, you wait for 2 to 3 months, not more than that, because we don't want to create any addiction for these patients. And generally, we take up them for other modalities of treatment. And role of
uncoated.
See, we already discussed, uncoated in those patients where we have just been introduced in the market for pancreatic pain, but it's no longer used in this patient, no longer used for that. Young adult with no pain, but dilated duct and calcification, no diabetes, should the duct be drained endoscopically or surgically, anticipating later problems? I think, at present, for chronic pancreatitis, we have no justification to do any intervention if the patient has no symptoms. There is a thought process earlier or even now, those who have been intervened, those who have been operated, those patients, the chances of malignancy, other complications can come down. But then we need more data for that. Present, we have no data to intervene any patient, and especially an young patient. That the question why this is why Dwariga. There's a question it has been asked. Probably, I think once you arrest this progression at a very young age, can we prevent further damage of pancreas. That is what the question, the mind of the question. That is, you can reduce exocrine insufficiency, you can reduce diabetes development. I think, we have no data to say that we need more data or such documentation for that. How many CP patients can be kept successfully on medical therapy? How many would go for surgery? How many are kept from surgery? Although medical therapy failed. See, if you look at the whole number of patients, 1/3 patient can be managed with medical therapy. The rest will ultimately go some sort of. This is actually not a lifelong procedure, but no time bound. At least temporarily we can maintain them for 1/3 patients. But majority of the patients ultimately they may go in for surgery or pancreatic endotherapy. It depends upon the ductal morphology, depends upon the stone oleum and the presence of stones. There are many factors involved in that. So I think at least a small subgroup of patient can be maintained on medical therapy.
I will slightly mix the two questions asked by Dr. Ramesh and Dr. Kanwalji. So young patient, symptomatic pain and hugely dilated duct, large calculi in the head, body and going up to tail. Would you still give medical therapy to this patient or would you straight away go for surgery?
I will prepare this patient for surgery, but I will improve, that I answered already, I will improve his nutrition.
Yes.
I will reduce his pain and I will make him more comfortable for the surgeons to handle him.
Dr. Saraswat, your concluding remarks for about 3 to 4 minutes.
Well, I think most of these issues have been dealt with and as much depth as the time permits by Dr. Philip. I think points that are coming up repeatedly in the questions that need reiteration is that today there is no convincing data, and in fact there are negative studies to the effect that pancreatic enzyme replacement therapy, whether coated or uncoated, does not help in pain, does not give pain relief, and should no longer be recommended for pain. What is clear is that pancreatic enzyme replacement therapy needs to be given for exocrine insufficiency. Now, many of us prescribe the right doses, but many of us in practice observe that our patients seldom take the medications in the doses advised for the simple reason that they are expensive medicines, and symptoms of troublesome steatorrhea, etc., get alleviated with relatively low doses. So you'll often find you prescribe 3 tablets, they're taking 1 tablet, they're not gaining weight. Biochemical monitoring with fecal fat excretion shows no marginal improvement in steatorrhea. Nevertheless, this state of the order of matters continues. So that is there. Now, I think in many of the questions, medical manage has been taken as a short form for pain management. So when you go to surgery, you don't go to surgery for exocrine, endocrine insufficiency, for other aspects, all of which is medical management. So regardless of the need to go to endotherapy or surgical therapy for pain management, medical management has to be implemented in all patients because there will be nutritional deficiencies, as Mathew has pointed out. Their exocrine, endocrine insufficiency has to be monitored and treated, and other issues are there. So medical therapy would remain applicable to every single patient with chronic pancreatitis over a period of time.
Yes.
The other issues are, I think, await a lot of data. CPN or celiac plexus block, I think Mathew has rightly mentioned that in chronic pancreatitis, in case no other option is available for reasons of frailty or ill health or being unfit for surgery, one might want to resort. But as a primary modality, it has almost no role because it gives very transient relief and is not a very repeatable modality. Whereas in pancreatic cancer, for the short-term alleviation of pain, it is a fairly useful modality. I guess
time is over.
Most of these aspects. Right. Okay, Vinay, back to you.
Can I make one point again?
Yes, please go ahead.
Just that, make sure that you don't tell the patient not to take fatty food. Always tell them take adequate. You pay for pancreatic enzyme replacement therapy and tell the patient not to take. This is a very common thing I see. Telling by the physicians or surgeons, reduce your fat intake. No, actually it's incorrect. Always you tell them take normal fat intake. Then only the PERT will work and he will improve on weight. Thank you so much for this wonderful.
Can I make a quick comment?
Yes,
Just half
Jyoti.
minute.
Yes,
Ah,
please.
Jyoti,
So,
please.
yeah. So the other thing is about the dietitians. I have stopped sending this patient to dietitians because I think they should be more sensitive about the biology of the disease. Invariably, they'll give a blanket treatment. Don't take this. Don't take moong ke dal. Don't take all this. Don't take idli dosa. So I think that's not correct. I mean, dietitians also needs to be sensitized and so that the patient gets the benefit.
Physicians
Thank you.
also. Physicians also.
Yeah, physicians, of
Refer to
course. I mean,
Dietitians, yes, Roop Jyoti is quite right.
I think physicians are more, we have to educate physicians more on that. Jyoti, thank you. Nice seeing you.
Thank
yeah,
you.
thank you. Same here,
Thank
sir.
you, Dr.
Same.
Philip. There is a compliment for you. Excellent talk by the speaker. And thank you, Dr. Saraswat, for chipping in at the last minute. And Dr. Ramesh also says there is no evidence that any diet will relieve pain. So I think we are more or less on a consensus here. So with that, we end the first session. Thank you very much. To chair the next session, may I invite Dr. SS Sharma. Dr. Sharma, could you please put your video on, please? Camera on. Dr. SS Sharma recently retired as a senior professor and head of the Department of Gastroenterology at the SMS Medical College, one of the largest medical college hospitals, not only in the state of Rajasthan, but I think in the country, with huge patient load. And he's one of the senior gastroenterologists of the state of Rajasthan. So he's going to chair the presentation by Dr. Saraswat on endoscopic management of chronic pancreatitis. Over to you, Dr. Sharma, please.
Good evening. I think endoscopic management of the chronic pancreatitis is the most important cornerstone treatment for the pain as well as the various complications of the chronic pancreatitis. And Dr. Saraswat, with a vast experience of endoscopy, I think is the most suitable speaker for this topic. I invite Dr. Saraswat to speak on this.
Yeah, just to interrupt, Dr. Saraswat was my colleague for more than 3 decades at SCPGI, and now we are colleagues at the Mahatma Gandhi Medical College Hospital. He is the chief of hepatology at our new institution, and he has done a great service in establishing a liver transplant program at the Mahatma Gandhi Medical College Hospital. Dr. Saraswat, please.
I'll share my screen.
Yeah.
Thank you very much for those very kind words, Vinay and SS. So I will try and cover the area of endotherapy for chronic pancreatitis in the next 15 minutes. As Mathew felt, so do I, that time allotted and the topics to be covered, there is a disproportion. But nevertheless, to move on. What are the situations in patients with chronic pancreatitis where endotherapy may be required? The first and foremost, the indication is pain management. And pain in these patients is generally related to pancreatic ductal hypertension based on pancreatic duct obstruction, which may be due to calculi, due to pancreatic strictures, or both calculi and strictures in the same patient. Local complications may arise like the development of a pseudocyst or an inflammatory mass, or even a tumor in the head of the pancreas, which can result in pain. Biliary obstruction, interestingly, also has been associated with pancreatic type pain, and relieving this obstruction may go a long way in alleviating pain in some patients. And finally, particularly in those who abuse alcohol, retroperitoneal nerve involvement that Mathew touched upon briefly could be a factor that is contributing, and each one of these is amenable to endoscopic management. Then biliary tract obstruction due to strictures at the lower end of the bile duct, which may be benign strictures there, or maybe large calculi in the head causing obstruction, development of a tumor. And in rare instances, we have seen patients who develop portal vein thrombosis as a local complication of pancreatitis, develop a portal cavernoma, and can develop biliary obstruction, which requires treatment in its own right. Then another complication of chronic pancreatitis is the development of pancreatic pseudocysts, which can be drained, used to be drained earlier with plastic stents. Now, US-guided drainage with the placement of expandable metal stent or lumen-opposing stents has come in, particularly if there is a walled-off necrosis, which can happen when there's an acute exacerbation in a patient with chronic pancreatitis. And of course, there could be external pancreatic fistulae or internal fistulae due to pancreatic, resulting in pancreatic ascites, pancreatic pleural effusions, all of which are amenable to endotherapy. GI bleeding, well, that does come under the purview of the endoscopist due to gastric or esophageal variceal bleeding. Rarely, you also have hemosuccus pancreaticus in acute exacerbations, more often in acute pancreatitis, where the endoscopist has more of a diagnostic rather than an interventional role, except as my colleague Dr. Pravir Rai has shown from SGPGI, can splenic artery aneurysms or the others can be some aneurysms that cause bleeding can be injected by EUS guided glue injections in these people. Now, as you can see, the extent and the requirement, oh yes, the final thing is, at times when you use plastic stents, they migrate, and the endoscopist, its onus is on him to retrieve these when they have migrated. So the gamut, the spectrum of endoscopic interventions in CP is indeed huge, and I'll try and cover only the aspects of pain management to some extent in the limited time available to me. Now, as you all know, pain in pancreatic chronic pancreatitis is due to intraductal hypertension, and surgical as well as endoscopic interventions that decrease intrapancreatic pressure result in the relief of pain. Other factors that are shown here may also contribute in some patients, and particularly those who have alcohol-related chronic pancreatitis. In many of our patients, and in fact, my largest experience has been with the idiopathic chronic pancreatitis in our country, where elevated intraductal pressure seems to be the dominant mechanism contributing to pain, which, as we have talked about, could be calculi, stricture, or the combination, as Dr. Reddy had reported way back 20 years ago, and that is borne out in the subsequent large works that he and Dr. Manu Tandon have published from the Asian Institute of Gastroenterology. We have various options. I left out the medical options. They are there because Mathew has covered them. For pain management in chronic pancreatitis, where calculi are causing obstruction, you have the options of extracorporeal shockwave lithotripsy with or without ERCP. We've already discussed celiac plexus blockage and its limited role in the question answer session earlier. And of course, a major mainstay historically and currently in many patients would continue to be surgical drainage of the main pancreatic duct, which will be covered in the subsequent sessions. I'll spend some time in talking to you about extracorporeal shockwave lithotripsy and endotherapy. The patients who need it, one can look at this diagram and see that when the calculus is obstructing the main pancreatic duct and is producing downstream hypertension, the pain becomes significant. In this, intraparenchymal pressure is also increased. And as you can see in this pancreatogram, some stones in the head, and particularly this at the genu that is causing obstruction, needs to be tackled to relieve pain. And only occasionally does standard endotherapy using sphincterotomy, dormia extraction actually work. Situations in which following lithotripsy or otherwise you might have an impacted stone in the papilla causing pain could be tackled by standard approaches that one use for bile duct stones, that is balloon extraction as shown here. But by and large, most stones in chronic pancreatitis are quite large, lumen occluding. They are adherent to the wall. It's difficult to get a basket beyond them, and endotherapy, standard endotherapy does not work. These patients are candidates for extracorporeal shockwave lithotripsy. Indeed, the guideline is that a single radiopaque calculus more than 5 millimeters or 3 or more calculi of less than 5 millimeters should be treated by ESWL rather than standard endotherapy. The strategies used is lithotripsy, which may be and followed by spontaneous expulsion and expectant management in a minority of patients that I'll come to later, or ESWL followed by ERCP to clear the fragments. And the timing of ERCP, some people would want to actually do a sphincterotomy before they undertake lithotripsy, because after lithotripsy, the edema, the petechiae in the mucosa may pose difficulty in cannulation. But most people would do endotherapy after the rounds of ESWL, and whether it should be early, intermediate, or delayed, there is a variation in the literature. But delayed generally results in better success rates of almost up to 90% in terms of clearance of fragments. Now, lithotripsy, the shockwave generators could be electrohydraulic, electromagnetic, or piezoceramic by these manufacturers. Basically, shock waves are generated in the degassed water by the, for example, in the electrohydraulic using a spark gap electrode, and These shock waves are then focused by an acoustic lens on the target, which is the calculus within the body, be it renal or pancreatic. And these shock waves are guided into the body by a water cushion, which is apposed closely to the skin of the patient who's being treated. The energy levels vary, and this is 0.54 millijoules per square millimeters would correlate with the highest energy level of 6. This is for the Dornier machine. Generally, 3,000 to 5,000 shock waves are administered under conscious sedation, but more often, especially if endotherapy is to follow, under anesthesia, the general anesthesia. And the mean number of sessions using these shock waves have ranged in reports from 1.3 to 6 sessions. So this is a patient being focused for ESWL, which are calculi being visualized by fluoroscopy, which is preferred, and particularly bimodal fluoroscopy, so that you can actually target it very accurately rather than ultrasonography. And generally, the most proximal calculus near the head, in the head of the pancreas, near the papilla, is first focused and fragmented, and then one can go down the duct, and multiple sessions may be needed if there is a heavy stone burden. Now, coming to the results of pancreatic lithotripsy in the early years, this is a summary of about 17 series that were published between 92 to 2013, over 3,000 patients. Over 1,000 of them were published by Manu Tandon from AIG, over 1,006. They reported a combined fragmentation rate of about 87.5%, and complete clearance rate of 60% was the median clearance, ranging from about 40 to 75%. And the most recent updated series from AIG has gone up to over 5,000 patients with a 90% successful fragmentation and over 72.6% complete clearance of calculi. The success of ESWL with or without ERCP is in successful fragmentation being achieved, as well as relief of obstruction, all of which is objectively documented by X-rays and imaging. Decrease in radiographic density of the stone can be visualized once it fragments and gets pulverized. The stone surface area increases, and the heterogeneity and a powder-like material in the side branches can often be visualized on plain X-ray. Reduction in pain, decrease in main pancreatic duct diameter, and easy deep MPD cannulation would signify relief of obstruction. Predictors of successful clearance is the presence of single large stones, which form the large bulk of even I think over half the patients from the AIG experience. Absence of a main pancreatic ductal stricture gives you better successful clearance, and calculi with low radio opacity, less than 1,000 Hounsfield units. For example, you often see filling defects which are radiolucent. They, of course, are very easily extracted and may not require fragmentation with ESWL. Some patients will recur 1/3 over 77 months of follow-up, and this is when there is a main pancreatic duct stricture or incomplete stone clearance. Continued pain despite successful treatment of the calculi could be, as I think Mathew has pointed out, if the patient continues to smoke, continues to abuse alcohol, when the likelihood of development of diabetes dramatically increases, and when there's a prolonged duration of pre-existing disease. Now, does endotherapy like this and clearing the duct, does it improve exocrine or endocrine function? Well, the answer is a mixed maybe. And what has been seen is in exocrine function, if you were to resort to relatively early treatment within 3 years of onset of painful chronic pancreatitis, rather than years or decades later, steatorrhea progression may be delayed so that you may hold the disease rather than regress it. And this may be for as long as 10 years before de novo steatorrhea in these patients appears. And similarly, it may reduce the risk of de novo diabetes mellitus. Complications, no mortality reported with this in the various studies and trials reported, and less than 7% have major complications like post-ESWL pancreatitis, bleeding, infections, stone fragment impaction, or perforation. And acute pancreatitis you can prophylax with the use of rectal indomethacin, as one does routinely in most forms. I'll quickly take you through a few pictures.
Three more minutes, please.
Yeah, so I'll take you through a few pictures for clearance of stones. So if there is a dominant stricture, as is shown here, balloon dilatation with a hurricane balloon positioned within the stricture, and after one or usually many sessions, you may achieve clearance of this duct. Often stents are required for this. And this shows a bundle of stents placed in the pancreatic duct for keeping the stent open for variable periods. If stents migrate, microdormia baskets can be used to remove them. This is a patient with incomplete pancreas divisum in whom a 12-year-old boy with recurrent pain, when a guide wire cannulation from the main papilla was done, this very funny contour of the wire was noted, which was explained when dye was injected and you had a massively dilated dorsal pancreatic duct with multiple calculi that seemed to be joining the ventral duct close to the point of the major papilla. And upstream, you can see the duct to the body and tail. With dormia and balloon extraction, the stones could be cleared after a good sphincterotomy at the major papilla, and then the anatomy became clearer. Dorsal ventral union happening here, I mean, the duct joining the dorsal duct and the body and tail. And as we did balloon occlusions and swept, we could appreciate that this was incomplete because the dorsal duct collapsed and a more normal contour ensued. The ventral duct, ventral duct is seen here. And the pancreas divisum, that upstream, the dorsal duct is visualized. Another young man who had intractable pain and significant weight loss, when we attempted treatment at the major papilla while the bile duct could be cannulated, at the main dorsal duct across the spine, we couldn't enter, although the uncinate duct was repeatedly cannulated. Possibly radiolucent calculi were obstructing. So we attempted cannulation at the minor papilla, which was unfortunately successful. And a markedly dorsal duct, dilated dorsal duct with a radiolucent filling defect was seen. And between the ductal dilatation and the minor papilla, a long, narrow stricture could be seen, which was then treated with balloon dilatation. And you can see a prominent waist on the hurricane balloon, which could be inflated and abolished at this time. And subsequent follow-up after the first session, here are the endoscopic pictures, major papilla, minor papilla, attempting cannulation, sphincterotomy, and failing to get into the dorsal duct. So trying the minor papilla, where we could do a sphincterotomy and dilate the minor papilla with a balloon, following which the initial stent was placed, and which was a very tortuous course here and a tight stricture, but could be straightened out later. This patient required 4 sessions totally of endotherapy spread out. Once he was pain relief, he wouldn't turn up. And here you can see the stricture appears to have become more pliable, although it persisted when the stent was removed. And we could put in 2 10 French and 1 7 French stent in the second session, which could go up to 4 stents, 3 10 French and 1 7 French in September. And in April 2023, roughly a year after we started, 15 months after we started, we had no significant waste on the balloon, and no stricture could be noted. And now the patient is pain-free, gaining weight, and off stents for the last several months. Pancreas divisum, resulting in chronic pancreatitis. I think I'll run through this fast. Major papilla didn't really show us, we allow us to enter the dorsal duct. So despite adequate attempts at the major papilla, we were sure of the minor of the divisum anatomy suspected on the MRCP, and minor papilla cannulation could be achieved, from which we could opacify the dorsal duct. Apologize for the poor quality of the video. And we could see the duct till the tail that we could be seen. And then minor papilla sphincterotomy could be carried out, followed by the placement of stents and balloon sweeps to clear the dorsal duct. That's a stent going in. And I think I'll skip this. This is a migrated stent that was removed.
We'll take the questions now. Dr. Sharma, please.
I think I'll give me 2 minutes to go through the guidelines, which is important for at least give you an overview of what has to be done. The European Society of Gastrointestinal Endoscopy has made certain recommendations in 2019. ESWL as the first line therapy for painful, uncomplicated chronic pancreatitis with an obstructed main pancreatic duct. ESWL, ERCP to be added in case there are incomplete clearance, and the size of stones I had mentioned is re-emphasized here. Factors that predict the good outcome and thus should guide us in endotherapy are listed here, and I covered some of these in my presentation. Stenting to treat the strictures is recommended, but most of us follow multiple side-by-side plastic stents rather than surgical therapy. No place for enzyme therapy. Antioxidants can be used for these therapy, as the ECG says. And surgical therapy is recommended in case first line approaches like endoscopic and pancreatic drainage have been exhausted or are unsuccessful in relieving pain. Thank you very much for your attention.
Dr. Sharma.
Hello.
Yes, sir. Please.
Thanks, Dr. Saraswat, for a very simplified presentation of the management of chronic endoscopic management of chronic pancreatitis. The questions, where are the questions? I don't see any questions.
In the chat box. So there was a question which was asked earlier by Dr. Jaipal Reddy. Dr. Saraswat, maybe you can take that at 7:38 p.m. because you touched on pancreas divisum. So you can take that question 7:38 p.m. Dr. Jaipal Reddy.
In the chat box, is it?
Yes. I will read it out. Young patient, type 3 pancreas divisum on MRCP, multiple stones in the uncinate alone. Rest of the pancreas is healthy on CAT scan with acute episodes once in 3 months, no diabetes, no malabsorption. What should be offered?
See, if there is significant pain, as you're saying, there is pain, he needs pancreatic ductal drainage. These uncinate process calculi are not responsible for the pain. And I guess drainage of the rest of the duct through the minor papilla, as I've shown in a couple of the patients that were discussed earlier, would be a good way to treat this patient. And in case pain still persists after ductal decompression while minor papilla sphincterotomy has been achieved, I guess then you could resort to extracorporeal shockwave lithotripsy to clear the uncinate process. I, in my own experience, have had a few patients like these. And once the dorsal duct that drained, that's the bulk of the gland is drained through the dorsal minor papilla, they are usually pain-free and may not need much attention to the calculi lying in the uncinate.
There is another question, the last one by Dr. Jaipal again. Maybe you can take that in the chat.
Practical case scenarios is that should in CP, which should proceed to surgery upfront without considering any form of endotherapy. How to complete multiple complications with a one-time solution by surgery. Well, I think the patients, a single large calculus obstructing, causing pain, they should be endotherapy, especially with ESWL, works very well. The direct surgery would be if there's a very heavy stone burden and the entire duct is packed, and it would take multiple sessions. I remember one patient who's insisted on not undergoing surgery. We had to do almost 5 or 6 sessions of ESW at Lucknow before we could clear the duct that was lined with stones from head to tail. That means a certain cost, and only in patients who are unfit for surgery or refuse surgery would one do endotherapy in this case. So these would be some situations where one could consider directly treating them with surgery. Now, one time vis-a-vis repeated attempts, I think that is a call that is the equation needs to be offered to the patient, the cost, the benefits, the versatility of ERCP. You come in, you go out the next day, you spend very little time in hospital and recovery time and have relief. The multiple sessions are required in case a stricture has to be treated. If you have the 30% percent patients that are presenting with strictures will need reiterative treatment to tackle the stricture. The others, a single time one or maybe at the most 2 sessions of endotherapy would suffice in clearing the stone burden and rendering the patient pain-free. Hope that answers you, Kamalji.
Yeah, there was another question at 7:49.
Okay. A 36-year-old male, history of alcohol, CCP with a large single stone in the head of the pancreas, attempted ERCP failed, developed acute and chronic pancreatitis with bilateral pancreatopleural fistula, managed conservatively with ICD. CT showed portal vein thrombosis with cavernoma. Can you add some more complications, please? Almost 10 months, asymptomatic and pert on buscopan, stone still there. No fistula tract is seen on MRCP, no varices. When should we intervene? Well, the patient will tell you when to intervene. If the patient is pain-free and not requiring pain, for some reason the stones are disimpacted, it is usually challenging scenario for the endoscopist, for the surgeon to attempt anything in this patient. The surgeon will probably have to do a shunt if a vein is available before attempting to go anywhere near the pancreas in this patient. If this patient were to have repeated recurrence of pain forcing you to intervene beyond PERT, ESWL is out. In patients with cavernomas and vessels in this region, you cannot use shock waves. So you are left with the standard endotherapy, and whether that will or will not relieve by pancreatic drainage or attempting fragmentation. At Lucknow, we have had experience of managing patients without ESWL because our machine broke down the last couple of years and we couldn't get a new machine. So if one is persevering enough and the patient demands it and it needs it, you are able to actually, with multiple sessions and mechanical means, fragment some stones. Now there are reports of laser lithotripsy of pancreatic duct calculi when you go through the main pancreatic duct and use laser holmium laser to fragment these stones, which could be attempted in these very difficult situations. Otherwise, you are back to stenting or bridging the stone, draining the gland and keeping the patient on stents. Hope,
for the audience, I'll read a comment by Dr. H. Ramesh that if you see stones in the uncinate process, it could be a red herring to indicate an underlying pancreas divisum. So look for it. There is a question by Dr. Vijay Bada. Maybe you can take that, 758.
Right. Is there a cutoff on the number of PD stent exchanges? When do we declare completion of treatment by endotherapy? Now, I think endotherapy is complete once there is no you are able to show that the stricture has gone or is negligible and is not causing obstruction. I think I showed in one of the slides that there should be relief of pain. There should be free pancreatic drainage, and a deep cannulation of the pancreatic duct should be possible, which would mean that there is adequate access and drainage of the gland happening when we call it. And most patients are treated with up to 3 to 4 stent exchanges until you achieve a near normal caliber. In my own experience, when we put in these stents and you place a stent bundle, the number of stents decides how long you have to keep it in. If you're going to keep a single stent in and out, you can continue doing it indefinitely without influencing the stricture too much. So I tend to place multiple stents if the ductal anatomy will permit, so that the stricture gets remodeled and you have a reasonable diameter of the duct. Because as we all know, the normal duct in the head, 5 millimeter, does a good job of drainage. And in a dilated system without calculi obstructing, the drainage will be satisfactory. You do not really need to go beyond that diameter for achieving drainage. And 2 to 3 sessions of stent exchanges should suffice.
There is a complication presentation.
Yeah, complications with
lamps.
Yeah, we didn't cover lamps here. Lamps is only would be for W1, walled-off pancreatic necrosis, or maybe pseudocyst, which has a large amount of solid or debris in there. Now, the problem with lamps is that it is an expandable metal stent that expands and compresses the wall of the tissue. And there have been reports with lamps left beyond 4 to 6 weeks in which at removal, there can be bleeding due to vessel being eroded in the wall because of the lamps is exerting constant high pressure. So that is a major concern. And now most people who place lamps for even WON would like to remove it by about 4 to 6 weeks after it has been placed. Incidence of gastric fistula, I am not sure I've seen any gastric fistula. Yes, large collections eroding into the stomach and creating a fistula with the retroperitoneum. These have been reported and noted more often in the duodenum, but occasionally in the antrum. But as part of treatment of pancreatitis, I don't recall seeing any. If there's a large gastric fistula, which is symptomatic, people have now placed Ovesco clips over the scope, large clips, which for bowel perforation, for a gastric leak, for any esophageal perforations, are in the hands of the experts who place it properly, are very effective in closing many holes in the GI tract at different locations.
Dr. Sharma,
yes.
Last minute comments.
Yes. Thanks, Dr. Saraswat, for highlighting the importance of endoscopy in management of pain in chronic pancreatitis. But one question should be there, that any patient with recurrent pain or pain of pancreatitis without significant dilatation of the duct, one should not attempt endoscopic management, because such patients are least likely to benefit from the endotherapy. So there should be significant dilatation of the duct. Many people are attempting without dilatation, producing complications. So that should be very clear that there should be dilatation of the duct.
You have to demonstrate obstruction of the main duct for before therapy. Thanks for bringing
Thank
that
you.
up, Dr. Sharma.
Thank you. Thank you, Dr. Sharma. Thank you, Dr. Saraswat. So we are running about 5 minutes late. We move on to the next session, which is going to be chaired by Dr. Adarsh Chaudhary, who is the Chief of GI Surgery at Medanta in Gurugram. And the presenter is Dr. Rebala Pradeep from AIG. Pradeep, can you come in? Yeah. Dr. Adarsh, please.
Pradeep, welcome, and the stage is all yours.
Can you see my slide, sir?
Dr. Pradeep's topic is indications and timing of surgery. Yes, Pradeep, we can see.
Good evening, Professor Kapoor, Professor Adarsh, and Professor Saraswat. So I'm going to present the indications and timing of surgery in chronic pancreatitis, a surgeon's perspective. All of us know it's an inflammatory process involving the peripancreatic tissues, and the treatment is challenging. And all the treatment we directed towards chronic pancreatitis is only palliative. And it is achieved by multidisciplinary approach, and that's why the controversies happen. And one should realize these approaches are complementary and they're not competitive. So you should know which one to go where, and that is ultimately it is a patient all of us should look at the patient's response, not that I can do or he can do. So most important is this, they should be looked at a complementary rather than competitive. Now let us look at the complications which require some sort of intervention. This can be a medical or endoscopic or a surgical. The most important component all of us look at is the pain, which occurs 70 to 90% of patients. And there are various complications like the biliary ductal stricture, a duodenal stricture. You can have an extrahepatic portal hypertension or a pseudoaneurysm and pseudocyst, ductal disruption leading to pancreatic ascites and a doubtful pancreatic head mass to be inflammatory or a malignant. And of course, an exocrine endocrine insufficiency, which requires mainly the medical treatment. These are the complications, and you have all the options of medical, surgical, and endoscopy. Now let's look at the pain, which Dr. Saraswat has already highlighted. The commonest symptom is the pain, and the mechanism of pain is we do not understand. It's poorly understood. That's why a lot of failures is because we don't understand why these pain occurs. The conventional old theory is that there is an obstruction, ductal obstruction leading to increased pressure and parenchymal pressure, and that leads to the pain. By decompression of this obstruction should lead to the pain relief, but it does not happen always. A small percentage of patients, even the duct is not dilated, or even after decompression of the duct, the pain continues, and this probably is due to entrapment of sensory nerves, or there can be an extrinsic pressure of a complication or a nociceptive transmission. So where the pain may be actually away from the pancreas, it is in the spinal cord or in the cortex. So we really do not understand the pain mechanism, why it happens in chronic pancreatitis. So as the first speaker highlighted, the main important is stop alcohol and smoking and analgesics of NSAIDs, the WHO pains and the step their pattern, and the narcotics should be restricted to the last options. And you have the adjuncts like antioxidants and pregabalin, and 30 to 60% of patients fail to respond to this conservative treatment during the course of the disease, and they might end up in interventions. Options like endoscopy or ESWL, which Saraswat has highlighted, and surgery, of course, in patients who do not are not candidates for endoscopic therapy, or where endotherapy fails, these patients will end up in surgery. And the approach to this surgical approach depends on the duct morphology, the strictures, presence of stone load, whether there's any inflammatory mass, whether it is localized to one part of the pancreas or the whole pancreas, or associated complications. These are all the issues which decide what should be done in a patient. So we look at ESWL and endoscopy. We had the AAG has a maximum number. Recently, as Manu has presented. If you look at these studies, most of the studies are short-term pain relief is very good, but when you look at a long-term, the pain relief significantly drops down to less than 60%. So one should all realize that a short-term pain relief with endotherapy is very good, and the relief is good, particularly when the stone is confined to the head. It's a limited stone load, and stricture confined to the head. These are the cases probably an endotherapy or ESWL will be beneficial. A huge stone load across the whole of pancreas are not ideal for a ESWL endoscopy. If you look at the conventional surgical results, most of the results, even late results of surgery, are very good to the tune of 90%. So we should compare the long-term results of the surgery versus endotherapy, where endotherapy long-term results are not that good. So then came the randomized trials, which a lot of criticism was there with these randomized trials, and they showed that though early results of pain relief is good with endotherapy, but when you look at the long-term results, the surgery has got a better long-term results, the pain relief compared to the endotherapy. Then people started looking at why not first apply endotherapy, and then once endotherapy fails, refer the patient to surgery. That is the step of approach. So conservative treatment failures. If the pain does not subside, conservative treatment, favorable morphology for endotherapy in the form of ESWL, stent, and failure of this endotherapy to surgery. The question is how long one should persist with endotherapy. Is it 6 months, 1 year? These patients continues to have pain in spite of endotherapy, frequent visits to the endoscopist for exchange of stents or putting new stents. So when should you refer to a surgeon? If you look at this same study of the 5 years after the Cohen study, the pain relief of surgery was 80% with surgery, but endotherapy is only 38%. And roughly about half of them are converted to surgery. And number of procedures required when you persist with endotherapy is very high. So they also sub-analysis was done. Salvage surgery, that means where endotherapy failures, where surgery was offered, the pain relief was not very effective. And the endocrine insufficiency was less frequent in those patients who were surgically treated. So this is one of the important observations which they have found, thinking that probably one should know when to refer surgery. And if you want to refer surgery, it should be done much earlier. This is ESCAPE trial, which is another clinical trial, randomized trial, where 88 patients were studied with the dilated ducts, where they included only patients with short-term opioid usage, and 44% upfront surgery and 44% endoscopy first approach. That means endoscopy failures will go for surgery in these patients. So the follow-up was only short-term of 2 years. The pain score was found to be low in upfront surgery, and complete or partial pain relief was achieved in a greater in number of patients, 58% in upfront surgery and 39% in endoscopic upfront. So early surgical intervention for pain within 4 years after the onset of symptoms produces good results. The choice of procedure should be dictated by the morphology of the duct and extent of pancreatic involvement. Early surgical intervention, probably the efficacy of pain relief is good in these patients, and probably there's a lot of debate whether it preserves the pancreatic function with the early surgery. Now coming to other complications like biliary stricture. So this is a pancreatic inflammation which involves around the pancreas, and this can lead to edema or even fibrosis, and this can lead to bile duct narrowing. This can be a transient or permanent, or the associated pseudocyst sometimes can produce an extrinsic impression on the biliary system, producing a stricture. And they present most often, they are asymptomatic, and pain because of the stricture, it can present as jaundice or cholangitis, or a late presentation or improperly treated, they can present biliary cirrhosis. So how will you approach these patients? The mild fibrosis, with a stable liver function test, probably you can just hold on. But if the edema, usually it resolves. And there's severe fibrosis or recurrent acute attacks, it can progress and lead to the complications. The approach to biliary structure can be observation or an endoscopy or a surgery depending on the extent or a progress of the stricture. Asymptomatic with mild dilatation, mild elevation of liver enzymes can be observed, and when there is no other indication for surgery, like no other complications. Close monitoring is mandatory. Though some people suggest a liver biopsy every 6 months, but not always agree on this of a serial liver biopsy every 6 months to pick up liver cirrhosis in these patients. The symptomatic cholangitis requires an intervention, associated biliary stones, or a biopsy evidence of biliary cirrhosis, the progression of obstruction leading to imaging evidence, or a persistent jaundice for more than 1 month. Or if the alkaline phosphatase is more than 3 times the normal and it persists for more than 1 month, these are the situations where one should intervene to prevent progression to cirrhosis. So endoscopic stenting is useful as a short term, but not for a long term, because long-term stenting, you have the problems of stent blockage and recurrent cholangitis. Endoscopic stenting is reserved for high-risk patients for surgery, or probably bridged to stabilize the patient prior to surgery, whereas nutritionally poor or cholangitis. So multiple, if at all you have to stent, multiple plastic stents are better, as Saraswat has told, and metal stents are initial better response, but the problem will be difficult to retrieve when you want to remove during surgery is required in these patients. So if you look at the success rate of these biliary strictures, is not a great, long-term success is not that great, but though long-term success of a self-expert metallic stents are much more than a plastic stents. But if you look at the surgery of biliary strictures, the excellent long-term results, acceptable mortality and morbidity and associated surgical problem can be simultaneously tackled when you surgically handle these biliary strictures. The procedure of choice is predominantly mainly choledochoduodenostomy and choledochojejunectomy, which is a Roux-en-Y. If the obstruction is because of a pseudocyst, one can do the drainage of the pseudocyst. But if there's a head mass, probably a resectional procedure of the head mass can open up these bile ducts and might not require any drainage. So this is the algorithm for management of these. It basically depends on whether the pain is predominant or no. If pain is the predominant symptom, when is there a jaundice or not? If there is a jaundice, probably one should consider a surgical drainage. When there is if there's a mass, one should go for a resectional procedure. If there is no mass, a simple drainage with a pancreatic duct along with a biliary drainage is what is suggested. So most often we do a phrase and a hepatic jejunostomy of the same loop rather than a choledochoduodenostomy in these patients. Now the other complication is a pseudocyst. Most often about 9 to 30% of these spontaneous dissolution, but it is less common compared to the acute pseudocysts occurring on acute pancreatitis, because most of them will have a ductal communication and they have a complications around 10%. These cysts can produce compression of the CBD or a duodenum, or it can involve the mesenteric venous system, or it can rupture, pancreatic ascites, bleed, and infection, or some of the complications these pseudocysts can develop. So,
Pradeep, sir, 2-3 minutes, please.
Yeah. So high risk pseudocyst, which is more than 4 centimeters, or an extra pancreatic cyst, should also be treated in these patients. These are some of the indications of treating the pseudocyst. A complicated pseudocyst should always be treated, or a symptomatic pseudocyst. Asymptomatic high risk cyst, because of the fear of complications like a large cyst, extra pancreatic cyst, should be treated. So the options are endoscopic versus surgical. You have a cyst depending on the anatomical location. And resection surgery, particularly when you have to do when the disease is confined to the tail or head, a resection procedure can also be considered in these options. The results of the endoscopic drainage is good, with a failure rate of about 15% and similar results with the surgical results. So both endoscopic and surgical drainage have a high success rate. No good comparative studies are available with the endoscopy versus surgery in pseudocyst. And multidisciplinary approach should be tailored to the patient and the pathology. And another complication is a duodenal obstruction, which can be because of the edema or fibrosis or a pseudocyst. And this is a long, smooth narrowing of the duodenum, which is producing an obstruction because of the inflamed pancreas. And it can be associated with biliary obstruction. The trial of conservative treatment for 2 weeks advocated, because edema, if it is because of the edema, it usually subsides. Otherwise, depending on the associated complications, you have to drain the bile duct along with a GJ or a duodenal jejunostomy. If there is a head mass associated with a duodenal obstruction, probably head resection or with or without drainage of the duodenum is advocated. The other complication is a mesenteric venous thrombosis leading to portal hypertension, presenting as a bleed, or it can sometimes, there will not be any bleed, but they create problems for us to go in and operate for a pancreatic or jejunostomy or bile ductal drainage. So morphology of this mesenteric venous thrombosis, they can present with only portal hypertension without collaterals, or the extensive collaterals for a surgeon. It makes the surgery becomes very difficult and bloody. And the most usual difficulties one encounters is identification of the pancreatic duct when there are collaterals, and the bleed during head pouring or identification of the bile duct. The approach is a meticulous, slow approach with in these patients, or sometimes when the surgery becomes more difficult, probably a prophylactic central shunt followed by the definitive surgery. Other presentation is a venous thrombosis, a bleed. So endotherapy is the first option, and surgery reserved when the endotherapy failures, or if the portal hypertension is because of the splenic vein thrombosis, probably a splenectomy is a permanent answer to this. So this is the algorithm which Professor Ramesh has advocated in his publication, saying that when there is a normal liver with various bleed, it is an endotherapy. If there is a no bleed with the pancreatic pain, the pancreatic procedure is advocated. But the surgery becomes more technically more challenging because of these dilated collaterals, a meticulous approach, or sometimes we can do a prophylactic shunt followed by surgery at a later date. To conclude, early surgical intervention for pain within 4 years after the onset of symptoms, good long-term results, and the choice of procedure is by the morphology of the duct and extent of pancreatic involvement. Early surgical intervention probably might preserve the pancreatic function, and early intervention in a biliary stricture will prevent biliary cirrhosis, and pancreatic head mass requires early intervention, particularly when the underlying malignancy cannot be excluded with confidence. Symptomatic high-risk pseudocyst needs intervention. Endoscopic or surgical treatment depends on the location of the cyst, presence of another indication for surgery. Portal hypertension with collaterals need meticulous surgery or a stage surgery with a shunt, and bleeding varices requires an endotherapy, or a left side portal hypertension requires splenectomy for a permanent cure. Thanks.
Dr. Adarsh, maybe we can take the questions first and then your comments.
Yeah, sure. Vinay, go ahead with the questions.
Yeah. So there is a question by Dr. Vijay Bada. Is intervention, whether endoscopic or surgical, in patients with no pain justified with an intent of organ preservation, especially in a fibrotic disease? Because he says that most of them eventually will end up with some intervention. So maybe both Pradeep and Dr. Saraswat can take this.
I don't think without pain, without any complication, right now there is no enough data to suggest that the surgery is going to preserve the pancreatic function. So until and unless we have enough data, I think we can't say with confidence that we should intervene in these patients.
What about endoscopic intervention, Dr. Saraswat? Would you intervene?
I think the same rule holds true. All therapy is symptom-based. It's targeted at problems, not prevention. There are no data to show that any intervention will improve the outcome. The data that Pradeep mentioned and that I'd also referred to, early intervention in a symptomatic patient within months or maybe a year or two, that would probably mean relatively early disease in the gland. There you can preserve pancreatic function and prevent progression by relieving obstruction. But upfront to undertake therapy in an asymptomatic person with that intent, well, let the evidence emerge before any attempt is made in that direction in a routine manner.
Dr. Sadiq is there. Sadiq, is there some soft evidence that there may be some improvement in the function? And second, is there an evidence that there could be reduction in the risk of malignancy? Would you like to come in? Sadiq, if you are there. Because I remember in one of his presentations, Sadiq showed a slide, which I then borrowed from him also, where there was, of course, it was not a very good or very convincing evidence, but there was soft evidence.
Vinay, there was a paper from a Japanese study.
Yes.
There's a Japanese study which showed that if it's a long-term follow-up, but I don't think there's any convincing evidence of that. There's a Japanese study which said that.
Okay. Yeah.
Any more questions?
Yeah, there are some other questions. Let me just, I think they are in the chat. So, should you do a GTT to unmask a borderline endocrine insufficiency in patients who have no pain, no diabetes, with PT dilatation and calculi? Maybe Dr. Saraswat can take that. Glucose tolerance test.
I think you do HbA1c much better, and then you can also do C peptide things. That C peptide gives you a better indication of early diabetes. No, but I mean, what exactly is the intention behind identifying early diabetes? One needs to be clear. Are you going to offer this person surgical or endoscopic intervention? That we've already discussed, and that is not the case. We will not be offering them this treatment. And the only evidence is when obstructive pancreatitis with pain, if you intervene early, you preserve pancreatic function. That does not automatically allow you to infer that will also confer similar benefits. You may have logic with you, but you don't have evidence with you. So I don't think we can intervene on logic alone.
Dr. PuneetDhar, who was to be the chief moderator, he was busy in a case which went on long, so he's just joined. Puneet, would you like to say what you have said in the chat box? Please come in.
No, I just wanted to just say that for symptomatic patients, there's soft evidence, especially in non-alcoholic, that there might be overall organ relative preservation if we intervene early. But in asymptomatic, to justify that, as Dr. Saraswat said, I just echoing the same words. Absolutely agree. It's no point in doing it if for asymptomatic. There is the wording of that question is that how can I make this patient into a surgical patient? That's incorrect. The hint is probably wrong, because I've asked this in a lot of forums. The kids that what will you do? This is full of patient had pain 2 years back. Now he's asymptomatic. So a lot of them say it's full of stones. I'll do a pusto and all that. Looking at the CT scan. So in every exam they say that. So I think that's very important to emphasize, as Pradeep has said also, as well as Dr. Saraswat.
Dr. Adarsh, your concluding remarks, please. You are muted.
Yeah, can I ask a question to Pradeep?
Yes, please.
Pradeep, we rarely talk about pain in patients who have undilated duct.
Yeah.
So it's a very sad situation, and people publish papers, and but then if you see in real life scenario, these patients don't do well. What is your view on that?
Yes, they don't do well. The endoscopist is reluctant to operate. The surgeon is reluctant to operate.
Yeah.
So because we know the results are poor, and unfortunate patients, probably they most of them will land up in medical treatment, and they get addicted to many of these things.
I think you covered the subject very well, and I think
Adarsh, before you make comment, Himanshi has sent me a question which I will request Pradeep to take. Follow up for 6 to 12 months, and if the biopsy shows biliary cirrhosis, does it resolve with surgery? Question seems to be incomplete, but I suppose the student wants to know that if there is evidence of secondary biliary cirrhosis, would it resolve if you do the biliary drainage?
Early fibrotic changes, probably they have shown that it reverses, but once full established cirrhosis is not going to reverse.
And Dr. Ramesh has made a comment.
Take that also. Yes,
Dr. Ramesh has made a comment that he doesn't agree that undilated ducts give bad results. So, but in hands of ordinary mortals like us, they don't give good results. So we really need to understand how it works elsewhere. But in most of our centers, undilated ducts don't give good results.
Concluding remarks, please.
So Pradeep, absolutely enjoyed your talk and think it was a very balanced presentation. The overriding message is that mere presence of a dilated duct and stones is not an indication for surgery. So I think that's the primary message of your talk. I absolutely enjoyed it, and thank you so much for your time.
Thank you. Thank you.
Dr. Ramesh, since I have a minute, would you like to come in and say that what surgical procedure would you do in an undilated duct? Dr. H. Ramesh?
I would do a Frey procedure, and an undilated duct, if one takes adequate care to identify the duct and drain it, the results in the long term have been good. I think undilated duct, Adarsh's bad experience may also stem from the fact that many of these patients have been already intervened. Dr. Sharma made a wonderful comment that an undilated duct mustn't attract endotherapy. And we've had instances where post-endotherapy, patients have had such severe pain that we had to remove the stents in a hurry, and then soon after consider surgical treatment. And I'm sorry, Adarsh, you had
sorry if you're finished. Ramesh, I wanted to ask you a question. Some people, since you see so many of these patients, do you believe that patients who have undilated ducts, if followed up for a long time, will develop dilated ducts?
The question is a very difficult one to answer because many of these patients, there is no correlation between ductal diameter and the severity of pain.
Agreed,
That's a paper we are about to publish. So if you have a patient who has an undilated duct but who has severe pain which is disabling, interfering with his quality of life, you have got to tackle it.
I understand.
My request and my plea is that we shall not do 95% pancreatectomy. We shall not do Whipple resections, but we shall do coring with lateral drainage, which is eminently doable.
I agree. Because I once talked to Pramod Garg. Pramod Garg says, from AIMS says that these undilated duct patients, if you follow them up for a long time, eventually the duct dilates. I don't agree with that.
No, I don't agree either. There are many patients who have grossly dilated duct, but who have never had pain. So you don't need to intervene in them either. We intervene the symptomatic patient and the complicated patient, not the morphology of the gland.
Thank you so much.
Adarsh, I mean, the only data that, well, I'm wondering that Dr. Ramesh is saying that he has excellent results with the Frey procedure in non-dilated ducts. The only data we have, and I am not confusing undilated with small duct pancreatitis, we have from Hamburg, and the long-term results with the V-shape excision have been excellent. But these are the only centers so far I know that has published this data. But on the other hand, we can have a cephalic mass without a duct dilation, and we can have a shrinking head with major duct dilation. So those with a shrinking head, in my personal experience and from the data of 1,400 chronic pancreatitis, those with a small shrinking head have more severe pain and do benefit truly from the coring, whether duct dilation is present or not.
No, my question is to a patient who has no head mass, but simply an undilated duct has severe pain. If it's a head mass, there is no problem. We can core it. But I'm talking of a patient whose duct is 3 millimeter, has no head mass, but has severe pain. So what do we do to this patient?
May I answer that?
Yeah.
Yes,
I would still core the head, use the head coring to detect the duct. And then
Ramesh, but there is no head mass. How can you core?
I don't need a head mass to core it. I core all patients.
The normal, but
I
Dr.
core
Ramesh,
a normal pancreatic duct. That is the
Ramesh,
that's
as a group, your results in the dilated duct versus your results in terms of pain relief in this subgroup where the duct is not dilated, not drainable, as others said, by ordinary mortals. Is there a difference, or you achieve the same results in the undilated duct?
In 2003, we published the intermediate term results, and which is a median of about 40 months, and it was similar. Right now, we have long-term results which also substantiate the same. So if you've got a good enough drainage of the pancreatic gland and the duct, you can have a good result.
Yogesh, why nobody in the world else could do a V-shape excision apart from Hamburg?
Well, V-shape excision, honestly, V-shape excision has been our standard procedure for chronic pancreatitis. So even with cephalic mass, we do combine with the anchoring of the head area, the entire gland is addressed with a V-shape.
Yogesh, what Dr. Adarsh is asking, that why it has not become popular with other centers, either in Germany or outside Germany.
Yeah, may I step in and say that I did try to do the V-shape excision in the undilated duct, but then I found the duct, so I didn't have to do a V-shaped excision. I used it as a backup procedure in case I didn't find the duct at all, and I just had to create a V-shaped gutter in the pancreas, but I didn't have to do that.
I think we need
Thank you so much, Vinay. Thank you so much for this opportunity.
Thank you, Adarsh. Thank you, Pradeep. We move on to the last session for today, which is going to be chaired by Dr. Vijay Bada from Yashoda Hospital in Hyderabad. And the presenter is Dr. Biju Pottakkat, who is my former fellow from SGPGI in Lucknow and is now the chief of GI surgery at Jaipur Pondicherry. Dr. Vijay, please.
Yeah, good evening, sir, all of you. After this very good discussion on the medical and endoscopic management and the indication for surgery, Biju sir will just enlighten us on the technical aspects of the various surgeries that are available at hand for treating a patient with chronic pancreatitis. So Biju sir, over to you, sir.
Hello.
Yes, Biju.
Yeah,
Hello.
good evening and thank you. Overall, there is a philosophical bias in the surgical procedure. So when surgery is spoken, I feel that suddenly the discussion of pancreatitis, we treat it like a hepatitis, incurable disease, entire pancreas disease. And when endoscopic approaches are spoken, suddenly we talk about ductal anatomy, classifications, stone disease, and all that. But at the end, probably in the last decade, chronic pancreatitis surgery became a very safe operation. And very few centers actually report mortality, and we have a very fewer complications overall. So the surgical results are improved tremendously, and this has to be accounted for. So overall, various classifications are there for surgical procedures, but generally they are drainage-only approaches, drainage dominant approaches, resection dominant approaches, and only resection approaches. So the earlier surgeries, Duval's, Pusto, and Partington's, they basically, with respect to the pancreas, they were only drainage only approaches. So when Freys and Isbicki and other people introduced this sort of some partial resection, but ultimately they were all drainage dominant approach. So the dominant part of the surgery was still the drainage, and the resection was the subsidiary component of that surgery. So further, it went into resection dominant approaches where there is actually a en bloc or a piecemeal block resections are done rather than coring. And the idea was to preserve the duodenum and the bile duct and something short of a pimple, plus or minus with the drainage procedures. So resection only approaches are also there, like a total pancreatectomy, islet transplantation, pancreatoduodenectomy, distal pancreatectomy for specific indications. But this may come up if islet transplantation comes to a bigger arena. So overall speaking, what are the intraoperative targets if you opt for surgery? This is after opting for surgery. Most of the recent publications show that you have to remove at least a significant part of the head. It is better to preserve the bile duct and the duodenum. And you have to remove almost all stones and drainage of all pancreatic ducts. That means all the three major pancreatic ducts. This should be the targets in probably in the current era for any surgery in chronic pancreatitis. What is probably not recommended now is if you are operating, only drainage of main pancreatitis is probably not recommended, and only some part of coring of the head, leaving behind the disease remnant duct without managing the strictures and stones also not recommended. So why we are still, whether the disease in the tail, body, or head, why we are concentrating on head? Because there is a philosophical pacemaker theory, and head region constitutes more volume. So whatever, whether it is Isbicki or head resection, whatever we are talking, the better results came with reducing the volume in the pancreas. That is where the better results of pain came, with reducing the volume in the pancreas. And head coring or head resection reduces the volume significantly. And head is the common location for stone, pseudosis, strictures, and most of the complications of chronic pancreatitis happens in the head. And head is a dominant location identified as the cause of pain, and the other two ducts are located in the head. So head coring is the most common procedure performed. But the problem with head coring is it's an anatomically less defined operation. You can do it minimum, you can do 5 gram, you can do 30 gram also, still call it head coring. And whenever the results are compared, all these surgically little bit less defined targets for performing surgery, all of them are compared in the same series, and ultimately the blame is put on the nature of the disease. Even if negative results are there, it is blamed on the nature of the chronic pancreatitis. So one of the least defined, anatomically defined operation is what we do is the Frey's procedure. So removal of all stones, majority of the head part to be removed, and drainage of all three ducts has to be done. And the idea of this surgery is you concentrate more on the head rather than body and tail. What is preserved in head coring is bile duct, duodenum, vascularity to the duodenum, pancreatobiliary ductal junction ampulla, posterior wall of the cavity, and bridge of the pancreatic tissue between SMA and posterior wall. So this is what is probably short of a people. This is what we have to we can preserve. Remaining we can remove. So why phrase procedure accepted very widely? Because it forms an extended drainage procedure. When you do phrase, it is mostly guaranteed that all ducts are opened up, and salvaging surgeon for the LPJ, which is probably considered as an obsolete operation now, and avoiding pancreatoduodenectomy, and any even less trained pancreatic surgeon can do this phrase procedure. But when you go to the original description of Frey, he himself defined it as a resection procedure, and probably the intention was to preserve the bile duct and duodenum and core out the majority of the head, and that's what probably the intention was the same what we are discussing even today. So there are original and modified approaches. The modified approaches, the coring came more anteriorly when the laparoscopy surgery was introduced, but this coring line now is shifting more posteriorly in most of the large volume centers. That is probably the message we are trying to get, is the coring line is shifting more posteriorly. So the problem with the conventional phrase is probably what is defined at that time was we stop at the area of the posterior most duct. So you can see in the picture that a significant amount of pancreatic tissue, especially in a highly inflamed gland pancreatic head mass, it is left posterior to the duct, and there can be stones there as you have seen in this picture. The problem with the chronic pancreatitis, especially patients with significant pain and other symptoms, is there is a dominant, there may be a regional dominance. Some patients' head may be a dominant site of disease, whereas in other patients, it may be the tail. So all patients are not the same, and the management has to be decided based upon the CT scan and what you see in the CT scan. So these two, both are chronic pancreatitis, but the approaches should be a little bit different in both the patients, because one is probably a head dominant disease, other is a ductal dominant pattern. And what we are discussing about the parenchymal dominant pattern where stones are scattered everywhere, and this also probably the head resection will help. At the same time, when you partially resect the head, ducts should be open, duct will be visible in the head. You can extend it from the head to the tail. There is no need to identify the duct at the neck or the tail region before resecting the head. So there can be a situation where the head can be severely diseased with a severely diseased tail also. So the bottom line is this: your surgery has to be on the right side. It has to be somewhere near the ampulla you have to stop, and the left side is to go right up to the splenic hilum, and the duct has to be completely open. Otherwise, the leftover stones and the undrained ducts, the results will be bad, and it will be blamed for the chronicity of the chronic pancreatitis, and actually it may not be due to the incomplete surgery. And the pseudocyst is nowadays we encounter is very often in chronic pancreatitis, and there is a risk of leaving pseudocyst in the head region if you don't core it or excise it very nicely. And so what we have to basically do is drainage of body and tail duct till the caudal pancreas. So if you talk tail of pancreas, the tip, the distal most part of the pancreatic duct, the caudal pancreas might be left behind because of the splenic artery injury, vein injury, but that has to be opened. And if you have a stuck stones there, it is better to resect. And duodenum bile duct has to be resected, remaining you can remove. So probably basic operation which fits to the most is head coring variably extended in the head. You may add an Isbicki procedure plus or minus, and adding ductocystogenosis, what we call the duct and cyst anastomose together. So this is probably a term which we are also trying to push it like a ductocystogenosis, where in chronic pseudosis, you open this cyst and only cyst drainage is not enough. Still, you have to do a head coring along with the anastomosis to the cyst, even if it's located in the remote locations. So these are some of the pictures of cystoductogenostomy we have done. And intraoperative ultrasound is a very essential tool, especially in patients with a portal hypertension or stuck stones in the tail region. So you can use various energy devices, unipolar, bipolar, harmonic devices, whatever you use. Normally, without portal hypertension, the blood loss is acceptable, and it's probably a surgeon's choice. And your left hand behind a completely cochlearized duodenum, left hand behind, will give a very good clue about the extent of your head coring, whether you are actually gone much beyond the all three ducts in the head region. Even in portal hypertension, sometimes if the head region has less collaterals, you can still go ahead with the head coring, but sometimes it may be really difficult. So we little bit modified the head coring concept in this way. We go ahead with a more extended coring. So what we essentially do, the principle was leaving behind the pancreatic tissue behind the ducts will be problematic. And we extended the coring right to the posterior capsule. So what we do is we just take out the entire pancreatic tissue and we leave only the posterior capsule. This posterior capsule is in a normal pancreas, and chronic pancreatitis looks quite different. In chronic pancreatitis, you will have a thick posterior wall, posterior capsule, and it will prevent the leak. So we go right to the posterior capsule, completely removing that part. And finally, the picture will be like this. This is what we call a more extended coring. And finally, after the coring, it will be just a simple thick layer of the posterior capsule without much pancreatic tissue. So this is our modification, what we do nowadays. And we also go right to the medial duodenal wall. So you identify the common channel. Sometimes you cut off the sphincter. Sometimes you enter to the sphincter to the bile duct to check that it is fine with the feeding tube. And basically, what you are ensuring is there is no stricture there up to the ampulla. Sometimes you cut the sphincter for ensuring it. And the Wirsung and Santorini ducts are exposed nicely. So the difference is this is a little bit more of an anatomically defined operation. Leftover tissue is minimal, and you can also avoid a pancreatoduodenectomy.
3 more minutes, Biju. 3 more minutes.
Yes, sir. So the suturing, what we do not suture to the nowadays we do not suture to the pancreatic remnant. We suture to the duodenum on the entire C loop. And the suturing to the pancreas comes only in the body and tail region. Remaining will directly suture the jejunum to the duodenal serosa. And this is up to the July 20, the 10-year experience when we modified our approaches. When we compared with the 14 cases of bile duct intersection, that time our results were good. Nowadays, we do not perform a routine phrase at all, and we always perform an extended coring or extended resections. And we have done more than 40 of them now, and our results are, we don't have much complications. And except in one case where there was a small posterior capsule opening which was sutured, remaining patients had a similar outcome compared to phrase when we were doing phrase. And one of the probably anecdotal incident what we have noticed frequently, the number of readmissions has significantly came down, although it needs a long-term follow-up. And thank you very much, and that's what I wanted to say. Thank you very much.
Yeah, so before Dr. Vijay takes over, Biju, for the sake of students in the audience, can you please again clarify what is phrase, what is conservative phrase, what is extended phrase, and what is modified phrase, and what is your modification? Because students are always asked this question in the exam.
Okay. So phrase is what we are preserving is in a phrase is the duodenum and probably the arcade of the vessels around the duodenum with some pancreatic tissue next to the duodenum, along with the bile duct, and the coring is done after up to just at the posterior level of the pancreatic duct. And on the left side, it is gone up to the neck of the pancreas. This is what is supposed to be the coring. So modified coring, modification in lesser way and greater way is also described. Lesser way is coring less than this, anything less than this, because when we see post phrase, we see some patient with post phrase done elsewhere. We also see significant amount of parenchyma left here. So this is less coring. More coring is you are going behind, much more excising all the ducts up to the posterior capsule. You are excising more to the duodenal margin and right up to the SMP. So probably there are 3 types of coring. I'm sure people may differ.
Yeah. Dr. Vijay, please take over. There is a comment by Dr. Puneet.
Yeah, thank you very much, sir, for your very elusive presentation and some of the modifications that you are bringing up to. First, we'll take Puneet sir's question. So, sir is asking that is cyst drainage required? Because you showed in one of the picture that when you drain the duct, you also incorporate the duodenocystogenostomy. So, his question is the cyst drainage really required when we are draining the main duct? Because obviously the control of the, we are doing the source control while draining the duct.
Yeah, the answer is we always do for various reasons. One, it's not mandatory that the ducts are always communicated with cyst. It can be a side branch, and we also found cysts are not in continuity very often on MRCP, and they can also be located in some remote locations which are not resolved or not accessible by endoscopy. Since we are operating and it doesn't add to the morbidity too much, we always add the drainage procedure along with that. That's a philosophy. But again, we have done almost around 14 cases like that, and we have to see our results.
Yeah.
Actually, they're quite
the same loop, I'm telling.
In all
we have done drainage separately before. I'm just telling about this procedure.
Yeah, all of the pseudocysts are not necessarily connected to the main duct. In most of the cases, we do see that. So you want to add something, Puneet?
Hi, can I? Yeah. So 2 things. One is he said if they may not be connected. If they are not connected, these are the classical ones which will resolve by themselves. Only the ones which are continuously being fed will be, will not reduce with time. So the ones which are not connected. So he also used the term not connected by MRCP. Now that is, you may or may not see, we've been burnt our fingers a lot of times about MRCP as being the gold standard. I think we need a direct kind of either an ERCP or a direct ductogram to show where the leak is, if there is a leak. Sometimes the leak is too small to see, which I completely agree. But if it is actually not there, we, theoretically, suppose we know that it's not there, it probably doesn't need drainage. Pseudocyst is not a disease; it's a complication. It's a leakage of the pancreatic duct fluid. So if we are draining the duct, we are actually, and there are papers showing that if you drain the duct in a cyst, in a disease, in a chronic pancreatitis associated cyst, you don't actually need the cyst drainage. The surgery is complete. There are a couple of papers showing this very elegantly. And if it is in continuity, then it's, even if it's a side duct, so long as you're draining the duct, you've actually decompressed. So there will not be enough pressure generated to reform the cyst or to maintain the cyst.
Yeah. Yes, sir. Biju sir, I have one question. You already said that head coring should be mandatory in all surgeries for chronic pancreatitis. But there are few studies which have shown, and now we know that we are cross-section imaging, we can measure actually the volume of the head of the pancreas. If there is absolutely no evidence of a fibrotic head of the pancreas, no mass in the pancreas, but a grossly dilated duct, what is that extended lateral pancreatitis, sir? Because there is a few studies as late as 22 where they have compared phrase versus the extended lateral pancreatitis, showing similar results in terms of pain control.
So I was talking about patients. So already you are decided for surgery, then head removal, probably retaining the bile duct and duodenum as a philosophical principle.
Okay.
Yeah, the evidence has to come, but it is still, I'm telling, it is based upon a philosophy.
Yeah.
The philosophy is what I have explained.
You have any experience of the extended PJ? What are the limits of the extended PJ, sir?
On the left side?
Yeah.
Yeah, so on the left side, what we do is we go up to the splenic hilum and the tip of, sometimes the tip of the pancreas, usually you cut anteriorly. You may have to cut laterally and open it on the left side. Exactly at the tail, you may have to open it laterally and anastomose it. That will probably ensure that. So the tail will just dip to the posteriorly and upwards. You have to open and make a lateral. Your lateral most stitch has to come actually in the posterior part of the duct rather than the anterior part in the tail. And here on the right extreme side, we normally go up to the common channel and sphincter.
Do we ligate kind of an amputation of the tail?
Yeah.
Yeah, amputation. And is it necessary to transect the GDA to in this extended pancreatic jejunostomy?
No, it's not, you need not go suprapancreatically and ligate it, but sometimes you may have to, mostly you will end up, sometimes you end up in ligating the anterior branch.
Okay, okay.
There are few questions from the students. Vijay, can I take
yes,
them?
Sir. Please take.
So since we have just 5 more minutes and I'd like to give Dr. Vijay 2 minutes to make some concluding remarks. Biju, quick one-line answers for exam. If we are not able to remove uncinate process stones during phrase procedure, what to do? First is, how do you find whether you have been able to remove, and if you feel, then what to do?
So the idea is intra-op identification of stones is really difficult. So it is better that if you see that pre-op imaging, it is affected, it is better to remove the gland rather than poking and removing the stones, because there is a risk of always leaving behind the stone. So in the head region, even the uncinate duct, you have multiple stones, better to remove majority of the part till a small area is left for anastomosis. That will ensure, basically the purpose main why the extended coring is giving probably better results. It actually ensures that all ducts are definitely drained. That is one of the sure guarantee it gives. But if you go with the mindset that I will do only the duct drainage, probably the duct drainage will also may become suboptimal. That's why when we normally do not identify the ducts at the neck or body, we during the process of head excision, we identify duct and extend to the body and tail. So that is the result.
Yeah. Next is that can we drain the bile duct along with the MPD drainage procedure in the same rule limb? Obviously, if it is indicated.
Yeah, it can be done same loop, but what we do is we always put one loop. We do not put a straight anastomosis. So you do a PJ, then the straight anastomosis ascending to the bile duct, that we don't do. We always put one loop down, and then the next loop only we do the anastomosis. In case it leaks, sometimes, again, I'm telling I don't have evidence for this particular thing, but we had maybe the bile flow through the PJ might be less. So put one loop down and then next loop you do. First loop PJ, next loop free, third loop edge.
Treatment of choice for chronic pancreatitis with pancreatic ascites, surgery or endotherapy?
I think I will not recommend surgery in the first sitting.
If the bile duct gets opened during phrase procedure, shall it be left open to drain into the cavity?
So it depends upon how it got opened. For example, you used a unipolar cautery and you try to score it and did the thermal damage. So I prefer to do anastomosis. And the second thing is, if the duct is too small, undilated and scarred, putting a stitch and closing it might be a problem. So either do an edge or just leave it like that.
And a step before that, how do you ensure that an undilated bile duct doesn't get injured during head coring?
How to ensure? Okay. So practically speaking, on table, by experience regarding the you should have a clear understanding of where exactly the duct is located. In this procedure, what I described, we sometimes put the instruments, biliary guides and all that through the ampulla and reverse direct and demonstrate this duct sometimes in difficult cases. And you can always, if you have a problem, you can always do a cholecystectomy or do a cholangiogram from above and see, and put a feeding tube down and see. But whatever the issue is, try not to injure the bile duct. And even if you injure it, do an AJ if it is because of the thermal injury. That's what my message.
Dr. Vijay, your concluding remarks, please.
Yeah, thank you, sir. It was a very good talk and a follow-up discussion on the most important aspect. I think one thing is very clear with the evidence and also the experience that head coring is a most important aspect of the surgery because only LPJ very rarely will be useful in the current set of the chronic pancreatitis patients that we are having. So we have to understand very clearly the marks of the boundaries of a good head coring. So head coring should be done completely. And as you said, that any intraoperative complications should be able to be held, dealt with very aptly. Thank you, Biju, for a wonderful talk and very good discussion after that one. Thanks, Kapoor sir, for giving this opportunity.
I think Puneet has a last minute. Puneet, would you like to? Dr. Puneet?
Yes, I just wanted to, No, sorry. No, I just was wondering whether we should, a lot of times we've had patients on follow-up who have, gallstones or gallstone-related problems or a biliary, so should we routinely add a cholecystectomy?
No, sir, I won't do because there's no justification, and on ethical grounds also, I don't think it is recommended.
Right, because some soft this thing that it might have been the pain we are attributing to chronic pancreatitis without actually any morphology, just because the two are coexisting, we are presuming it's because of that. Some small proportion may be, just like we say when you're opening right iliac fossa, should you add a appendicectomy with there? We don't say that it is irrational. No, I'm just wondering, because I remember the ones where a lot of times we've had problems with gallstones or with biliary drainage later on. So there's always like you said, we should do a cholecystectomy for doing the cholangiogram, which I completely agree. I think that's a very good idea. So just a thought, it's always crossed my mind when these patients come back with stones or some stasis.
Okay, thank you very much, Biju. Thank you, Dr. Vijay, and thanks to all the faculty and panelists who joined, and thanks to all the delegates who joined. So again, if the students want to join Jaipur Surgical tutorial, please send a WhatsApp message to Dr. Anand. I have been projecting his number in between. Please send a WhatsApp message to him. And we meet again tomorrow at 7 o'clock. Thank you very much. Good night. Good night, everyone.
Okay, good night.
Thank you, Himanshi. And once again, the technical support, as I mentioned in the beginning, is provided by Dr. Avinash, who's again one of my former fellow from SGPGI, now a practicing GI surgeon in Ahmedabad, and his team led by Himanshi Patel. Thank you. Thank you very much.
Thank you.
Thank you.